So I'm going to talk with you this morning about the prevalence of autism spectrum disorders, and I'm going to try to address the question that has concerned a great many people with respect to whether there's actually an epidemic of autism spectrum disorders. That is, has the number of cases really increased? You got me working, or can we see the next slide? Okay, we're going to try again. Bam. Okay, it worked. Okay. Well, did one. There we go. Okay, I hope this keeps working. So everybody seems to know what autism spectrum disorder is. And that poses actually one of the most challenging problems because it's largely been portrayed in the lay media in a variety of ways that may not entirely reflect the clinical syndrome. This is a number of movies that have been involved with individuals with ASD, and you can see they're quite dramatically different from one another. The lower left-hand corner is lower left, yes, is a recent movie with Ben Affleck about a man with autism who is also a deadly killer and an accountant. And again, each of these are characterizations that leave people thinking that they all understand in the general public about this disorder. And it really fails to capture the full spectrum and the nuances of the condition. Sorry, guys. There you go. I guess I hold it up like this. Now, you would think that the notion of autism spectrum disorder was something relatively recent, and much of the story seems to have evolved since the 1930s and 40s and beyond. But in fact, it's probably people have had autism or autism spectrum disorder for as long as there have been people. This is a picture of the French psychologist Itard and a young boy named Victor. Victor is on the right. And is written about in the late 1700s, early 1900s, when Itard discovered this boy living in the town of Aveyron and took him to Paris to try to train him. And Victor seemed to learn a lot of behaviors, but never learned to speak very well and never learned social skills. There's really one of the earliest clinical descriptions of ASD. But, oh, now it's working too well. But the name autism really was given to the syndrome in 1943 when Leo Kanner wrote a paper called Autistic Disturbances of Affective Content. And in that paper, he described 11 children, and they ranged in levels of functioning, and most of whom ended up in residential care, one of whom not only lived independently in the community, but is actually still alive today. And there was an article written about him in the Atlantic magazine a couple years ago. But most of them ended up either in residential care, and a couple died early. The causes of death, though, were largely related to epilepsy complications that we don't see today. But it represented the lower end of the spectrum of the disorder. There we go. There were lots of theories about what caused autism, and initially most of these theories were related to psychological causes. That is, that parents failed to properly rear their children, and as a result, they ended up with this profound social deficit and other kinds of problems. Of course, if you were a parent of a child with autism, this was devastating and didn't exactly fall on sympathetic ears. And eventually, the parents decided to do something about this, and they formed an organization in the United States and a parallel organization in the United Kingdom, and this one was called the National Society for Autistic Children. And in 1977, they pulled together a group of scientists and said, create some diagnostic criteria so we can define the syndrome and then start to look at how common it is and do real research on it. Now, the interesting thing, this was mostly mothers, the ones who were so-called causing autism. The interesting thing about this is these diagnostic criteria, as you look at them here from 1977, are very similar, if not almost identical, to the criteria that we use today. This is DSM-5 criteria, and you can see the persistent deficits in social communication. They've been reorganized, and problems in language and social communication. They've been reorganized, but basically the same symptoms persist in going forward now, 40 years later. Now, one of the concerns has been over this 40 or 50 year period that the prevalence has been increasing. This slide shows different countries and shows over a period of time, and you can see the prevalence increasing quite dramatically beginning in the late 1980s, early 1990s, but actually if you look carefully it sort of starts in the 1970s. This is another set of data that shows that the range in these prevalence estimates go from 1 in 150 to now 1 in 38, depending on the study. And I'm going to show you what the differences in this may be. But this has fueled the speculation that there's a tremendous epidemic of autism, that people are increasingly getting the disorder. But before we think about that, we have to understand the difference between prevalence, incidence, and then what is an epidemic. So prevalence is the proportion of a population having a particular condition or characteristic, and it's based on the number of cases present at a given time. And usually we refer to point prevalence at a given time. Incidence is very different, and people confuse the two. Incidence is the number of new cases in a specific time divided by the size of the population at risk. An epidemic is a dramatic increase in incidence. There are many reasons why prevalence can increase without having an increase in incidence. So there are many reasons why those numbers should be going up without there being a lot of new cases. Now I'm going to try to explain that in what follows. So what are the reasons? Well, first of all, the diagnostic criteria have changed. We have better tools for identifying. The research methods have changed. There's greater awareness. There are more services, and that's relevant. And there's a wider age range. And maybe there's an increased incidence. Now I'm going to show you data to support each of these notions. By the way, the age range one is quite interesting because it used to be that children weren't diagnosed with ASD or autism until they entered school. And then by the time they got to be 16 or 17, if they were disabled, they went to residential or custodial care and they were called intellectually disabled. And so when they counted prevalence, they only counted between 6 and 16. Now, if you start counting from 1 until 6 and from 16 to the end of life, just by itself, the number of people per unit population increases without changing any diagnostic criteria or anything. And we're now making diagnoses as young as a year, year and a half. So let's look at how diagnostic criteria can actually change the prevalence estimates. There are a number of studies using a variety of diagnostic criteria. And what you can see is that using the standard Connor criteria, you get a prevalence of 0.038%, and the criteria for the DSM-5 study, which we did, 2.6%. And it ranges in between just based on the criteria that you use to define the disorder. So has the incidence changed? No, just the rules for making the diagnosis change to cause that. And this is another sample for studies in the same population in Finland using 3 different kinds of diagnostic criteria, and you can see the prevalence estimates differ from 2.3 per 10,000 to 7.6 just by changing diagnostic criteria. So one of the things that's happened is that the diagnostic criteria have changed. And this is looking at different populations in England, and the same thing occurs with almost a 16-fold difference based on the way you did the study and the criteria you used. And so it's not that the number of kids in the UK with ASD increased so 16-fold in 10 years, but the way the studies were done and the diagnostic criteria used made the difference. Now, when it comes to thinking about applying the diagnostic criteria, there's also the matter of the instruments that we've used. And not only have we now come to an agreement about what the diagnostic criteria are, thanks to the NSAC group and subsequent DSM and ICD modifications, but we also have an internationally agreed upon gold standard for making the diagnosis. And that's using the ADI, the Autism Diagnostic Interview, and the Autism Diagnostic Observation Schedule. The interview is a structured interview, and the observation and the ADOS is an instrument that provides a structured clinical examination of the patient. And the interview itself comes with 4 modules, the first module for people who are nonverbal, and the 4th module for people who are quite verbal. And there are new versions of this for toddlers and now for nonverbal adults. So it covers the age range and it covers the spectrum disorders. So we now have a standard instrument so we can go across studies using the same set of measures. That helps stabilize our estimates of prevalence. Now this is a study, this is an example of service utilization. And this happens to come from the state of California, where they looked at prevalence of ASD based on service data. That is, how many children in the public schools in California were getting services for ASD. And what you notice is in 1977, a law was passed in the United States which made it a requirement that all schools provided free education in the least restrictive environment for all children. Prior to that time, the schools would say, "You're too difficult for us to teach, go home." And as a result, the children with disabilities, and in particular autism, were not taught in the public schools. So it wouldn't be surprising the prevalence would be low. When the law said, no, you have to treat them, all of a sudden the prevalence goes up. Does this mean that those kids weren't there? Yeah, they weren't in school, but they were still in the community. So this, again, this is a piece of data that we used repeatedly to show that there was an autism epidemic, when in fact, it only really reflects a change in service utilization. I'll come back to the service utilization question in a moment. Hello? We're here. We got it. Now, this is looking in the state of Minnesota and looking at a very similar curve. And one of the things that we see is that in ICD-10 and DSM-4, which, by the way, are the only diagnostic criteria that overlap between the two disorders, between the two systems, when ICD came, the breadth of the diagnostic criteria widened, and one of the things we saw is an increase in prevalence. So what you can see is a lot of secular events change the prevalence of a disorder, the change in diagnostic criteria, the change in law, and the change in service requirements. Now, what's really interesting about this is that service also plays another role. Because there were more services over time became available for children with ASD, and more than there were for children with intellectual disability, the number of children classified with intellectual disability declined at a rate roughly the same as the ones with autism increased. The prevalence of intellectual disability cannot decline. By rule, it is fixed at 2 standard deviations below the mean. So what was happening is, in service utilization, people would say, I get better services if my child is labeled with autism, so they get their child labeled as autistic, and then they would get better services. The number of kids with intellectual disability didn't decline. The number of kids with autism didn't go up. They just shifted. It's called diagnostic switching. Okay, so up until the early 2000s, nobody had done a population-based epidemiologic study of ASD. Now you'd say, well, that would seem to be an obvious thing to do, but it wasn't, because the general assumption that anybody who had ASD would show up in a clinic or get special education. This is a study that was done by Young-Chin Kim and her colleagues in Korea, and they did a total population study. They went into a community and they screened all the children in that community using the ASSQ. All those children who screened positive were then given formal evaluations with ADI and ADOS, and then they came up with a prevalence of 2.6% reported in 2011. This was an outrageous number that nobody believed, including the investigators at first. But when we break down the numbers, one of the things that we found was that 0.8% represented those individuals who had previously been diagnosed clinically and had gotten clinical services, special education or mental health services. And as it turns out, that if you go into clinics and you base your population estimates based on that, you'll get 0.8% repeatedly. Sorry, I didn't do that. Hang on, go back. And that in this particular community in Korea, 2/3 of the individuals were actually not receiving services, had not been previously identified. Now, this is a really important point for epidemiologists in general. If you only look in clinics, you're going to only find people who get to clinics, and not everybody can get to a clinic. They may not have insurance, they may not have transportation, there are lots of reasons, and they may not be sufficiently disruptive that it's necessitated them going to clinics. And so this speaks to the point that you have to really look at a whole population in order to get proper prevalence estimates. This number of 2.6% in 2011, you'll see, turns out not to be so far off the mark. And the other thing that we did with these data is we then re-diagnosed all the children using DSM-5 criteria. And one of the things that you find out on this slide is that the prevalence of PDD, of all types of PDD in DSM-4 was 2.64%. If you looked at DSM-5, it was 2.2% for just DSM-5 ASD. And then if you added the new diagnosis, social communication disorder, you ended up with almost exactly the same number. And of the few children who no longer met criteria under DSM-5, almost all of them, had another psychiatric disorder, whether it was social communication disorder or other disorder. So none of the kids were without disorder, but it was only about 3% that didn't make the transition. And they were all children classified as PDD-NOS. That is the nonspecific subtype. So again, this prevalence seems to hold even under DSM-5 criteria. Now, I said that something about awareness plays a role in understanding of prevalence. Certainly the movies that I showed you, but also campaigns like this one from the CDC, and there are many all over the world, have tried to increase awareness of child growth and development, and particularly paying attention to the possibility of delayed social and communicative development being associated with autism. Social awareness campaigns and public awareness just through Time magazine and newspapers and television shows have changed the perceptions of the possibility of autism. In fact, Sesame Street, just in the past week or so, announced that they now have a child who has autism on Sesame Street. It's a child named Julia. And so it's even gotten to that level. So public awareness increases the counting and the availability of people to be counted. Now, before I go any further, I have to stop and pay attention to a man who I prefer not to pay attention to. But in 1998, Andrew Wakefield, a gastroenterologist in the UK, made an assumption, published a paper in Lancet saying that autism and PDD were caused by disruption in gastrointestinal function related to MMR vaccine. And I'd point out that he's not a child psychiatrist. None of these kids were diagnosed using any standard methods. But it came to a point that it became quite clear to many people that MMR vaccine was a cause of ASD. This is not true. I want to be clear that it was not true. But many people continue now not to vaccinate their children. I want to give you some data just to show you that this is not just wild speculation on my part. The top line, the horizontal line, is the uptake levels of MMR vaccine in a particular population, and the red line is the prevalence of ASD. So with no change in vaccination rates, the ASD prevalence was rising. So there's no correlation, no relationship. We say, well, that's one study. And then they said, well, no, it fostered regression after 18 or 19 months in those children who were vaccinated. Well, these are data looking at the first onset of symptoms reported by parents in children with ASD. Prior to MMR, 19.5 months. Post-MR, 19.2, 19.3 months. There's no difference. So MMR didn't cause a regression, didn't cause early onset of symptoms. Again, no relationship. So when that didn't pan out, the people who were of Andrew Wakefield's group said it was the thimerosal or mercury in the vaccines. These are data from Denmark, which in the early 1990s took all the thimerosal out of the vaccines. That's the vertical line. And despite removing the mercury from the vaccines, the prevalence continued to increase quite dramatically, probably based on all the things we've already been talking about. So vaccines and mercury do not cause ASD. In fact, this is a meta-analysis looking at a number of studies and looking at the relationship between MMR vaccine and autism. And as you can see, it is protective. It is not causal. There's not even a single study that shows that MMR increases the risk for ASD. Unless you are still not convinced, we tend to forget that measles is a terrible disease. People who are in relatively well-established countries or in the Western countries or in developed countries where vaccines are available don't see measles much anymore. But in the developing world, measles is quite common. In fact, in 1990, about 2 million children died of measles, and of those who survived, about 20% had brain injury. So this is a terrible disease that is far more dangerous than autism. And the measles vaccine has essentially wiped it out in the developed world and is dramatically reducing it. In 2010, only 200,000 children died, only. That's a terrible tragedy. It's unnecessary. It's a disease that should be eliminated. But despite the data, many have divergent opinions. And I think this, as in many other cases of ASD, it's really important for clinicians and scientists to be explicitly clear that we understand many things about ASD, we don't understand everything, but the increasing prevalence is not due to vaccine, and in fact, vaccine increases the risk for developing ASD. This happens to be Andrew Wakefield and a couple of his buddies, who are not my friends. So I want to come back to the Korean prevalence study because I think there's some important things for us to learn from that. First of all, we used a total population sample, and in that population, 2.64% had ASD. Remember that number because I'm going to show you some other recent data. In the general population sample, that is, those individuals who were not involved in any clinical services, it was about 1.8, 1.9%, and about 0.75, 0.8% of the were in the clinical sample. Of those 2.64%, 0.94% had what was in DSM-4 called autism or autistic disorder. And the vast majority of others, 2/3 of them, had other types of pervasive developmental disorder. This is important because what happened is in DSM-5, we've gotten rid of all the subtypes because they're not particularly meaningful ideologically and they don't help us a great deal in understanding the course of the disorder. But what's interesting, when you divide the clinical from the non-clinical sample, you find some things that are very interesting. First of all, if you look at IQ levels, you see that, I don't know if this pointer works. No, it does. Oh, there it is. So if you see IQs, in the kids who are in the clinical sample, they had mean IQ of 75. That is, they were more severely impaired intellectually and had more significant problems. In the non-clinical sample, the mean IQ was in the average range. And so these were kids who were less impaired from a cognitive point of view, and they were less impaired behaviorally. If you look at their SRS scores in the second line, both of them had significant social responsiveness deficits. And if you look at the adaptability scores in the bottom line from the BASC, both had significant adaptational problems. It is interesting also to note that the sex ratios were quite different. 5-to-1 males to females in the clinical sample, whereas it was 2.5-to-1 in the non-clinical sample. So these are different populations, and if you only captured the clinical part of the population, you don't get the full spectrum of the disorder. And by looking at these kind of data, it helps us understand the kind of service needs we have to have and the kind of models we have to use for identifying kids at risk and for getting early intervention. So if we think about this transition from DSM-4 to DSM-5, will there be people left out? Probably not. A few of them, but they'll all have psychiatric disorders that require intervention. What's more important is that the diagnostic criteria work in terms of telling us that people have a disability that demands attention, in particular early intervention. So let's go back. Why is the prevalence increasing? Diagnostic criteria have changed. I've shown you that the broadening of the diagnostic criteria increases the prevalence. I've also shown you that there's diagnostic switching take place. I'm going to show it to you again. We clearly have better tools for screening. We have better tools for identification, and we'll talk a little bit more about making a diagnosis in a little bit. And there's absolutely more awareness. You wouldn't be here if there wasn't more awareness, both amongst primary care and mental health providers, but most importantly in the media and in parents who keep fueling this story. But there are other issues. Clearly there were previous underestimates. Part of it was using clinical populations. So we've got better methods for epidemiologic studies. But the study from Korea, which is a pretty good estimate, may not apply precisely in UAE or elsewhere in the world. And so other countries need to do their own epidemiologic studies so they can understand the service patterns that they have to address. There are definitely more services available, and parents who want their children to do better are seeking those services, and as a result, they'll reach out and self-identify, even overcome stigma. And I mentioned the wider age range. But is there an increase in incidence? Well, I'm sorry to tell you there are no incidence studies of ASD. Now, there are two reasons for that. One is that it's much easier to do a incidence study for an acute onset illness, like the flu or something of that sort, because it begins at a specific point in time, and you know when it begins, and you can start counting new cases. ASD begins over a time frame, probably beginning during the fetal lifetime and then into early childhood. And so there's not a discrete point where you can say the disorder started. The second thing is that it's hard to do these kind of studies because it takes long periods of time, and generally governments and other agencies are not prepared to fund those kinds of studies. I do have good news, and that is that we are actually in the process of completing an incidence study that should be done in about 18 months, and we'll be able to start publishing data from that. Now, we haven't really looked at the data carefully, but I think there's no signal to suggest there's a dramatic increase in incidence or an epidemic. And I'm going to provide you some support for that notion. These are data from the CDC in the United States. And there are important things on this that I want to bring to your attention. First of all, in the first column, it shows intellectual disability. And these are the changes from 2011 to the 2011 to 13 survey done by the CDC, and then the 2014 survey. First thing you see is that the prevalence of intellectual disability declined. It's impossible, can't decline. The reports in this particular survey reported fewer cases of intellectual disability. The second thing that happened was in your third set of bars, you can see that the prevalence of ASD increased to 2.24%. Oh, that's remarkably similar to 2.6% and a great deal more than the long-held view of 0.8%. So the rest of the world is catching up to us in Korea. We're much relieved to see that in one sense. On the other hand, it's unfortunate that it's such a common disorder in childhood. But the most important thing on this study, in these set of data, are the last two columns, which show that look at all forms of developmental disability. And you can see that they haven't changed at all over this period of time. If there was an event, toxic, infectious, or something that was causing dramatic change in rates of developmental disability, we would see these changes. But as it turns out, there's nothing changing. There's no evidence that there's a discrete cause of ASD, but rather that genetics, infections, environmental factors increase risk for neurodevelopmental disorders broadly. And we would expect that if there was such an event, it would increase the risk for intellectual disability and all kinds of other neurodevelopmental disorders. And that's simply not happening. Again, speaking broadly, against the notion of an epidemic. And lastly, we can look at the CDC Center for Health Statistics data for ASD prevalence, and we can see something else that's important. In 2014, suddenly the number rose to 2.4%. It was because there was an increase in people with ASD? No. The CDC changed the questions that they asked on their questionnaire, and so they captured more cases. And they were actually able to demonstrate in a sample that used the old questions and then resampled the same people using the new questions that it accounted for a significant portion of the increase. So here we are, not an epidemic, but back to basic methods. The critical point here is that ASD is a common disorder in childhood, one of the most common chronic illnesses facing children. Cancer in children, about which we hear a great deal, is 0.1% of the population. Diabetes, about 0.8% of the population in children. Asthma, about 2% of the population. ASD, 2.6, 2.5, 2.4. It's one of the most common chronic illnesses affecting children, and we have data to show that. It's not an epidemic. They've always been there. We just didn't look for them. Thank you very much.